All right, so what's up, guys? Welcome to Basically EMS, the EMS podcast for basic providers. I am Chris. I have been in EMS since 2009, been a medic since 2015, including about a couple years as an FTO at a local agency. Who else we got? How about you?
I am Mike. I've been a flight paramedic for about a year and a half. I was a ground paramedic for 5 years and went to IMA in 2016.
Whew.
Nice. I'm Ali. I have been in EMS since 2016. A little bit on the fire department, and then at Ada County as an EMT and a current FTO.
My name is Wade. I was my EMS career is 2019 is when I started. I did a year of volunteer with Ada County and 3 years paid as a full-time paramedic.
I'm still going to call you Nick.
It's my nickname.
Your nickname?
Yeah, it's my nickname.
That's right on. We're just going to call him not FTO, I think, because he's the only one at the table without it. So
How does it feel to not be a lieutenant?
Pretty good. I got no responsibilities, so I'm not mad at it.
all right, cool. So today we're going to talk about some closed head injuries, and so we would be remiss if we didn't start with a little bit of A&P just to cover that, so we're all on the same page. So pretty important. Head injuries obviously are a big deal. More than half the traumatic deaths are due to head injuries, so something we need to be really, really good about, recognizing what's going on and kind of knowing the reasons behind those things. So coming back to the anatomy, obviously inside of our head is this important thing. Do you guys know what that is?
No.
The brain.
The brain. Yes, it's not pinky, it's the brain.
Mm-hmm.
So yeah, we got the brain in our head. And so three main parts of the brain. We got the cerebrum. That's the big part of the brain, right? That's going to be 75% of the volume. And that's going to have our thought, our voluntary functions, those kind of things. Then coming down, we got the cerebellum, or the little brain, I believe is what cerebellum translates to. That's going to be coordination, or, so we'll talk about that as far as injuries there, or cerebellar strokes. I'm sure you guys are aware of cerebellar strokes. It's one thing we're looking for is ataxia and difficulty moving and all that. And then maybe most importantly in the brain, we've got the brain stem. And so that's the part of the brain that just keeps us alive. Those are the functions of heart rate, respiratory rate, those things, right? That just kind of do their thing to keep us from being just a sack of meat with no thoughts in our heads. Surrounding the brain, we have the skull. Yeah. Skull's broken down into, I think, 14 different bones. EMS instructor Wade, does that sound right to you?
Yeah, sounds about right. I think that includes, skull and face. So not just the cranium there, but yeah, the whole thing. When it comes to the skull, anatomy is an important thing. If we can understand what the anatomy is, we can start to figure out what potentially is going on. And the nice thing about the anatomy of the skull is that a lot of the anatomy is named similarly to the brain, which kind of makes sense because they live with each other essentially, right? So the frontal bone covers the frontal lobe. The occipital bone in the back covers the occipital lobe. Parietal bone, parietal lobe. Temporal bone, temporal lobe. So each one has its own kind of set jurisdiction there, and then within each one of the lobes, they have their own kind of job. So, occipital helps process sight, temporal helps process our hearing, our frontal is our conscious thought. Who we are essentially is your frontal lobe. And then the parietal, that's where it starts stepping into motion, and then you could even deep dive this even further. You can go into what the folds of the brain are, like gyruses of sorts. You can actually, there's one portion of the brain back when I did A&P back in college, we had a cadaver lab got to play with, which was really cool. But there's this portion in the center of the brain essentially where you can put a probe down and it can dictate the movement or the sensory response of a certain aspect of the body. So like it stretches kind of, if you look at the brain, right, if we look at it from that side view, it's going to stretch over the middle from left to right. And so from there, different portions control the arm, different portions control the legs. And so that's actually what I've come to find some neurosurgeons will actually do is they'll probe those areas while they're doing surgery just to see if they still have function. I saw a post recently about one where they were working on a concert violinist, and while she was under sedation, they had her actually start playing the violin a little bit, and then they were probing these areas to see if they were starting to influence or affect the movement of the fingers. The brain has a lot of different controlling mechanisms to it, and it's a lot more complex than what we really need to go to in this basic realm. But by understanding what the functions are and where they are, it's going to help you, at least with your decision making showing up on scene, right? Where's your injury? Okay, if it's to the back of the head, maybe vision's impacted. Oh, it's to the front of the head, maybe mental status is going to be impacted. Temporal, maybe hearing, right? So you can start putting pieces together that way.
Yeah.
You lost me at gyrus, but I keep it super simple.
A gyrus is a fold in the brain.
Well,
which also, fun facts, the smarter you are as a species, the more folds you have in your brain. So if you
I need more folds.
You're looking like a real smooth brainer. Yeah.
I keep it super simple. I don't have as many gyruses as Wade does, but I really think about the brainstem as kind of the big thing. I'm really concerned with, that the mental status, their heart rate, their respiratory rate, respiratory drive, and that's kind of the big first thing I'm looking at when I'm thinking through head injuries and anatomy overall.
Yeah, when we start to talk about recognition of these things, it'll make sense when we start to talk about heart rates and respiratory rates and all that, of why those things change as we have these brain injuries. Mm-hmm. Coming down, we've got the foramen magnum, which is just a fun word to say anyways, and we all know that's the opening, the only escape essentially in the skull. So if we do have that swelling within the brain or bleeding within the brain, we are liable to start herniating our brainstem through the foramen magnum, which is real bad.
Yeah. I think one thing on that could help if you're someone who has a hard time with anatomy is understanding the concept that foramen just means hole in a bone. So on the face, if you actually look at a skull, you'll see foramen on the mandible, you'll see foramen on the maxilla, you'll see them under the eyes. Foramen just means hole in a bone. So what do you think foramen magnum, if you're trying to put that piece together? Big hole, right? Mm-hmm. Foramen, hole in the bone, magnum, biggest. So it can kind of help put two and two together.
And this is where I tend to, when I'm teaching this subject and we talk about the foramen magnum, is that's where we herniate, right? And we herniate because the skull is a closed space. And so that's where the Monroe-Kelly doctrine comes in. So meaning the brain is 80% of that space, the blood is 10% of that space, and then cerebrospinal fluid is the rest of that, so the rest of the 10%. And that's a fixed space. So if the brain starts to swell for whatever reason, or we have increased amount of blood that has to make room, the brain's going to have to go somewhere, right? And so if the blood is increasing in that space, the brain has to shrink essentially, and it's going to shrink through the big hole in the bottom of the skull. So that's kind of the way I like to teach that.
Yeah, I think, there's got to be a little leeway, right? Well, maybe we'll see some shift and everything on brain scans. Maybe there's not that herniation, but at some point if it continues to bleed, that's kind of the end stage, essentially. If we start to see, normally posturing is what we expect to see for that herniation. I think the game's pretty much over at that point for the patient, unfortunately.
Yeah.
Mm-hmm. Yeah, and even if they're alive, who knows what secondary injuries, hypoxia being the big one.
Yeah.
Perfusion, hypoperfusion, end of the day.
Yeah. And then, so talking about the brain, around the brain we have the meninges, right? And that's going to be down the spinal cord as well. And so on the outside, we have the dura mater, is going to be that kind of tough fibrous meninge on the outside, the meningeal layer. And then we also have the arachnoid and the pia mater, which are going to be underneath, kind of closer to the actual spinal cord itself and the brain. And those last two, the arachnoid and the pia mater, are both going to have blood vessels. So important for us to remember that there can be bleeding within. They're kind of like little garbage sacks, right? That the brain is held into in a couple different layers. And if we tear within like the arachnoid space or the arachnoid layer, we can start to bleed within that arachnoid space. And so that's going to have its own kind of presentation if we have a bleed there.
Mm-hmm. And then kind of correlating with, 3 layers, 3 spaces. So 3 spaces that you could bleed into. Mm-hmm. Kind of talked about it, but getting back into like how I remember dura mater or mater, however you want to say it. Dura, durable, right? So outermost, so skull, dura mater, we want that second layer of protection to be thick. That way we're not, running the risk of something basically something being punctured really easily.
Yeah. Yeah, we have like a skull fracture. We want to, if there's bone fragments, we want to hopefully protect the brain.
Right.
With a kind of a tougher layer on the outside.
It's like the brain's leather. It's like the motorcycle.
Yeah.
It's kind of their outer protective layer.
Yeah.
Right on.
The skull being the helmet.
Yep.
Bingo.
Is your brain a 1%er?
No, I wish.
Reference, so, we've also got the CSF, like Mike was talking about a little bit. So the CSF is the cerebral spinal fluid. And so We typically will have 125 to 150 mLs at any point within the brain. That's going to be that 10% like we were talking about. And then that's going to be produced in the third ventricle is the name of where it's produced. So
there is a third ventricle.
There is a third ventricle.
Mm-hmm.
So yeah, knowing that's important, and then being able to recognize we know about the halo test, and so the halo test is where if you have a patient who's bleeding from a head injury, we're going to catch some of that in some gauze and look to see if there is separation, like oil and water, of blood and that straw-colored cerebral spinal fluid, right? So, you guys ever done a halo test before?
Yes.
Yeah.
You want to tell us about it?
Yeah. Car accident. She got tagged standing outside of her car, and the force threw her back. She landed on the back of her head and cracked it open pretty good.
Yeah.
So bleeding from the ears. Did a quick halo test. It was positive. Just a little drop of blood. And then on the outside, you see that kind of discolored, straw-colored fluid start to form. So that was good enough for me. Not really anything we can do about it in the field, but it is a good thing to tell the doctors because something in there has broken where it shouldn't be broken.
Yeah. Fluid's getting where it's not supposed to go.
We don't want that on the outside.
Yeah, for sure.
What were you saying about BGs and CSF?
Yeah, so this is from a nurse that I worked with. This is, I don't know all the details, but apparently in the ICU, sometimes what they'll do is they'll check blood sugars on, if they're bleeding and that kind of thing. And if the blood sugar is high, it means there's potentially a presence of cerebral spinal fluid. I'm not sure exactly why, what numbers they're looking for and when exactly they do that kind of thing, but it is something that is done. Not that I condone taking blood sugars. Hold on a second, hold them down to take a blood sugar, but it is something. Yeah. Hey, I've taken blood sugars in some interesting places over the years, but it's not something that I would say, we're going to take time to do, but just you might hear about it.
Confirming sign of anything.
Yeah. Yeah, and like we were saying, it makes sense, right? The brain is very glucose dependent. As you know, like the brain needs a couple of things, right? Glucose and oxygen being the most important there.
Yep.
And so it would make sense that the CSF will have a higher concentration of glucose, and that could increase the blood sugar range that you get if CSF is mixed in that blood.
Yeah, all about maintaining perfusion.
So let's talk about.
I didn't like the whisper.
That's why we do it, keeping you guys on your toes. So let's talk about the more fun stuff, right? Let's talk about what happens. Well, not fun for them, but fun for us, I guess, with some head injuries. So the most basic one to talk about, and as you can tell by how we talk to each other, we've all had a bunch of concussions. It's going to be concussions. So concussions are going to be a head injury, a closed head injury, where when they go to the hospital, they're going to look for any like objective brain injury and they can't find anything. So there's obviously been some sort of brain injury. They're showing signs and symptoms. They're symptomatic to it, but they're doing a CT or whatever, and they're not seeing bleeding. They're not seeing any contusions, anything like that, right? So. About 90% of those patients are not going to lose consciousness, so that's important for us as responders to remember that that's not our be-all, end-all, right? Like I talk about it like with shock a lot, that when I first learned, in my mind, shock meant low blood pressure, right? And if they didn't have a low blood pressure, they went in shock. And then when I, became a grown-up EMS responder and really like started to learn and pick up on how things actually are, I started to recognize like, well, that's really late. Like if they
already wait a minute.
if they already have a low blood pressure, there's a lot of things that happen to get there, right? And so it's important for us, same kind of thing with concussions, to recognize like maybe they didn't have a loss of consciousness. That doesn't mean they don't have a concussion there, right? So it's more patients don't have them than do.
I think it's easy for new providers, and I was the same way, to get just tunnel vision. You hear something out of the textbook, or you hear your instructor say it a certain way, and you think every patient has to fit into this box. But especially when we're talking about neurological head injury type of presentations, these patients aren't always going to look a certain way. We only have a very limited view of what we know. We don't have any imaging. We don't have x-ray. We don't have anything like that. So we have to go off of what we're seeing, the signs and symptoms that we have in front of us, and kind of the story, and put it all together. And so, but also being flexible that we don't know what we don't know, right? And so they're not always going to present a certain way.
Mm-hmm. Yeah, I think that's an important thing too. Is I hear a lot of people say they want to enter this field because it's something different every day. That's not really the case. It's somewhere within 15 to 20 different categories. What's different is our circumstances that get us there, right? So whatever scenario we end up pulling up onto, signs are signs, whether they're late or early, but can we find either one? Because don't bank on late signs, because the closer you are, or the more late signs you see, the closer they are to a case of deadness. So don't really want to get that one around.
Yeah. And despite what, the shows and movies make it seem like deadness is usually permanent, we're not that great at stopping that and turning it around, unfortunately. So
not me, that's for sure.
So talking about concussions, some of the signs we need to be able to recognize, right? So we all love the repetitive questioning confusion. We'll touch on that in a second, but some of the basic signs you might see is a patient complaining of dizziness, weakness, or inability to focus is pretty common. We'll see that a lot. I know, like, my little brother plays rugby, and he's had a couple concussions where they were really strict about, like, you can't watch TV, you can't play video games, you can't be on your phone. So that specific focus is really hard. The brain needs to kind of rest. And so that's really difficult, or maybe they just can't physically focus on those things. They can't focus on Mike, but that's just because Mike is boring. So it's hard to focus on sometimes.
Came out of left field, but all right.
Truth hurts, doesn't it?
Yeah, this is still kind of dry. I'm trying to liven it up a little bit.
All right.
So
idiot.
Where's Cody when you need him?
Visual changes and ringing in the ears are another one we might see, and that again, coming back to what Wade was talking about, where that injury was or where the impact was, would maybe start to affect that a little bit as far as what we're going to see there. Right. Slurred speech is another one we might see, and then nausea, vomiting is a pretty common one that we'll see for head injuries with concussions. Can be that nausea, vomiting.
And the downside of concussions too is they're a mimic, right, of sorts. If we think about someone who's intoxicated, alcohol intoxication, slurred speech, inability to focus, that checks out right there, right? And if we talk about we've all had that drunk patient who's fallen down, cracked their head off the ground. It can be a tough thing to delineate from. Is this alcohol or is this head injury? And that's where, understanding and reading the mechanism and honestly being convincing goes a long way. Because if they're drunk and they have a head injury, and they ain't gonna believe you, especially if they don't remember for whatever reason.
So always got to assume worst case in those situations. You can't just write them off as just being drunk. You never know. There's one that comes to mind for sure, working with one of our buddies that we know. A guy was very intoxicated, fell over, and was completely unconscious. And I was convinced he was just drunk. My partner was convinced it was all trauma. And really, in all reality, it was probably somewhere in between. But you really have to assume both in those instances. And you can't just write that patient off as being just drunk, because it can mimic that trauma for sure.
And that's something that trips up new people all the time.
Absolutely.
During assessments. You give someone an intoxicated assessment who's new to this field, they're going to struggle through it. I've had it a few times. How do I know this is not just some drunk guy on the side of the road? How do you know? You got to look, you got to ask the questions, right? And then a lot of that too is there a mechanism we can read? Is it vehicle related? Do we see anything nearby that maybe indicates there was some sort of fight, right? Physical altercation? You never really know.
Yeah, seeing clues.
Yeah.
And at the end of the day, you're going to do the safest thing generally, if you're not
be a patient advocate, no doubt,
and take them to the hospital, right? It's a lot easier to justify why you did than why you didn't take them to the hospital if you're not sure.
Be a good person.
Yeah. I mean, I'd rather take them to the hospital and be wrong, be called a dummy by a doctor, than miss something and then they die, and then I'm definitely getting called a dummy, if not worse names, by the doctor.
Or you end up back on them at 2 a.m.
Yeah.
And they're in much worse shape.
Yes.
Yeah. You were talking to me earlier. Now you're not.
Has your face always been melting like that?
So coming back to kind of some of the loss of consciousness, or a level of consciousness things we might see, right? So with a concussion, confusion is something that we might see, right? They might be a little confused, and I feel like this is typically going to be kind of a low level confusion, right, where they're mostly able to answer your questions, but a little bit confused. And then amnesia is common, especially being amnesic to the events that happened, so not remembering that they were, playing football and went head to head with somebody. They just don't remember that, right? And then repetitive questioning is another one that we were talking about earlier that we all have seen before and love. and they're kind of interesting patients to be on. Those patients, the first time you see it, you're like, whoa, I read about this in a textbook. You know, they can be pretty striking. So you guys have any good repetitive stories?
Yeah.
Before we go story time, though, before we go into story time, I should say I think the big thing with concussions compared to some of these other head injuries is we're dealing with potential altered mental status, not necessarily altered level of consciousness. And so I think that's really important to differentiate before we kind of proceed. These patients may be confused, but they're not necessarily, you know, responsive to verbal or painful stimuli or unresponsive.
They're alert, but their orientation levels affected.
Exactly. Yeah.
AMS.
Okay. Sorry, go ahead, Wade.
No, you're good. That's good points. Yeah. So repetitive questioning. I had a call with a partner, good buddy of mine. We were dispatched out to a psych facility or rehabilitation facility, and when we showed up, we were dispatched, I believe it was syncope or a fall, I can't remember. But we show up, patient hit his head on the table. Staff said he lost consciousness, hit his head. Find the blood, see the cut, 2 and 2 add up. So we start talking to him as at that point, or excuse me, we weren't talking to him, we were talking to staff who was holding him up in a seated position, which hypotension and upright head are not good friends. Typically mentation or consciousness dips after that. So anyway, I delegated my partner, said, hey, start getting vitals ready. I'm going to start looking through my bag. I'm going to start getting what I need out. And at that point, as we both turn around, we see him now no longer being attended by staff, clacks his forehead, then off the tile floor. Felt like a really bad provider in that moment in time. So immediately, of course, he bought a collar. That was a big whoopsie. Don't do that. But where he comes into that repetitive questioning is once we laid him flat, we returned circulation to the brain. He started talking to us, snapped back to. And then it was when he asked me, hey, can I tell you something without you getting mad at me? It's like, yeah. And he's like, okay, aliens. And then he just brushed past it like nothing ever happened. Then close after that was I abducted? No. Okay. So I'm answering these questions honestly. I'm trying not to throw this guy out of his mind because he's working his way there. And it was when that 5-minute reset hit. Can I tell you something crazy without you getting mad at me? Aliens. Okay. And then it got to the point where I'm reading ahead of him. Can I tell you something crazy? Aliens? How'd you know? Right? Like we're starting to put it together. And then, you know, the same thing with the was I abducted? Started with no's, got a lot closer to maybes and maybe a yes or two thrown in there. But he was resetting every 5 minutes to the point that, you know, it's like I'm pretty comfortable and confident this is a concussion. Pretty obvious.
Well, look at it from his perspective. He woke up in the back of an ambulance with bright lights and 2 dudes staring at him. He probably really thought you were the aliens in this scenario.
That's fair. I never thought of that.
Yeah.
Perspective's everything.
He's questioning you.
Yeah.
It's like aliens.
What
What are you gonna do?
I should have reached my finger out, you know.
Just do it the next time around and just like sneak a pen light.
Yeah. Hey, check this out.
Yeah, I had a good one too when I was in my medic internship. It was a dude it was a rollover accident, like younger teenage kid. And we were transporting him to the hospital and just like a, 1-2 minute memory loop. But every time he would ask us what happened, we would tell him that he was in an accident. And then his response is always like, oh, my mom's going to be so mad at me because he like totaled his car. And then my preceptor would love to tell him like, you think she's going to be mad now? Just wait till she sees the helicopter bill because we were flying him to the trauma center. So like really short memory loop to kind of see them just repeat. They'll ask you the same questions or say the same things over and over and over and over. And that's a good way to pick out that they have a concussion.
Ali, what's an assessment you've used for repetitive questioning? What can you ask them?
I'll give him 3 different words. So usually an object, a verb down, and then an adjective or something. So typically a color, but whatever you feel like giving them to remember. And then, 5, 10, 15 minutes, ask them the same question, see if they remember, see how long that memory span is. If they can't remember the first 5 minutes, then you got a pretty good concussion. But sometimes they'll remember it the first 5 minutes, 10, 15 minutes later, they might not remember it again. So kind of start figuring out the different levels or grades of concussions, but that's doctors to decide. So
Above our pay grade.
It's above my pay grade.
It's a lot above our pay grade.
I just go, yeah, you look concussed.
That's just my face.
I'm like, it's not
Do
great.
always look like this?
And that one thing I always talk about with students is, and some students will get in the weeds, or they'll get caught. They don't really understand our alert and oriented questions. You're talking about EMS, right?
Yeah.
And it's important for us to understand why we're asking the questions that we ask, and that's exactly why, like you were saying, because even if they're on a memory loop, maybe it's 1 minute or maybe it's 15 minutes, right? And we need to be able to make that determination. So if they're on a 50-minute time loop, maybe we're only on scene for 10 minutes and we don't recognize that they are confused or they do have that AMS. And so that's why it's really important for us when we're doing our alert and oriented checks to ask questions with different time spans to try to narrow down, because even an old person with really bad dementia could probably tell you their name. They maybe couldn't tell you anything else, but they should have their name because that's their long-term memory that they're accessing. Where if we start to ask, what's your name versus who's the president versus what day is it today versus what happened in the last 15 minutes, we're accessing all different parts of their memory to try to make sure that we are making a safe determination if they want to refuse or whatever, right? So that way we are defensible and doing the right thing for our patient because they are able to make that decision.
I've always got the classic, like looking at my watch, like what day of the week is it?
Yeah. I think a good way to view like your orientation questions is think about it like CMS, PMS. Right before we splint, we always check CMS. After we splint, we check CMS. Did we make a mistake somewhere in the line? You can do the same thing with altered mental status. Check before. We've asked a few questions. Maybe if, say it's a hypoglycemic, stretching away from trauma for a moment, but say it's a hypoglycemic, we give sugar. Ask them again, before and after. Can we fix, or did we fix anything, or are we making this worse? Type viewpoints.
Yeah. The dreaded GCS score. When you go back for charting purposes too.
Yeah. Know your GCS score. If you're a basic EMT or you're in EMT school listening to this, you will need to know that information. Maybe you'll have it in your charting software, but it's not that hard. Take the time.
And even then, like viewing GCS is, you're going to go through A&O if you can, but I always explain GCS of like, okay, let's say you can't talk to them. What's an objective way? How can we objectively find out how they're mentating? And GCS is your answer.
Yeah, for sure.
Exactly.
All right, so after talking about concussions, we're going to want to come and talk about contusions. So I think typically they're just going to have those normal signs of brain injury, kind of like a concussion. But this does have some sort of physical injury to the brain. So it's going to be a brain bruise, essentially, right, if it's a contusion. We can have that kind of short-term damage, or we can have that permanent damage, right? Like, you were talking about the different parts of the brain and what those affect. Like, you'll hear about people that have those brain injuries to the frontal lobe that are completely different people afterwards because of emotional regulation and all that kind of thing. So, that could be like a contusion. For us, for our purposes, though, we don't know. And so we'll just be looking for those standard signs and symptoms of a brain injury and just assume from there that they have a brain injury. It doesn't matter what kind of brain injury they have to us. They're going to go to the hospital either way.
Yep,
right?
Exactly. It doesn't really change what we're doing overall for the most part. Not a lot of these, until we're really dealing with ABC issues. We're not, thinking of different types of brain injuries too much. But, it's contusion versus concussion. There's not going to be a whole lot of difference that we're going to think about.
I think a good identifier, though, because if we think of like what a contusion is, right, like it's going to be that coagulated blood space taking up space somewhere. And if we're talking brain contusion, history is going to be your big one, right? Like how long ago did the trauma occur? If this is something that's like within 15, 20 minutes, maybe we're not thinking contusion because I don't know necessarily if it's going to form in that time frame, but kind of car wreck yesterday, well, that's a different conversation, right? And so time is going to be your big, I think, indicator with these.
So moving past that, we can talk a little bit about skull fractures. So a couple different types of skull fractures that we'll see. Linear fractures are going to be the most common. So that's just kind of exactly what it sounds like, right? Just a linear fracture, just a fracture in the bone,
straight
of the
line.
skull. Or maybe not even a straight line, but just kind of a line, right? Most of the time, or crack.
Little crack in there.
Oh, little crack.
Little crack.
Most of the time we can't recognize this, right? Like maybe we'll see something to the skin, like, we'll see some sort of skin soft tissue injury, but there's not really any way for us to know. They're not going to have crepitus. If you guys have seen the thickness of an actual skull, it's astoundingly thick.
Cause crepitus on a linear skull fracture. You're pushing too hard.
Oops. That was a linear skull fracture, and now it's not. That's mostly going to be recognized at the hospital when they run a scan to see the actual
imaging.
head.
Yeah, our X-ray vision's still in the mail. Haven't gotten a chance to use it yet.
One day.
Amazon Prime it.
Yeah, dude. AliExpress. It's taken at least 9 months to get here.
As long as it works. I know it would be like 17 cents. So.
AliExpress, once again, probably not going to work.
But it's cheap.
That's true.
And then we got depressed skull fractures. So those are obviously linear is just going to be a line. A depressed skull fracture will have multiple fractures or whatever to allow the skull to kind of be caved in a little bit. Mm-hmm. And I know for sure that our boy Wade over here has a good story about a depressed skull fracture.
I do indeed. So back when I was in college, me and my roommates, we were all college athletes. We decided we were finally free of sports, so let's get into intramural sports. So we decided we want to play basketball. All was hunky-dory. We sucked. We're soccer players. We sucked. But at one point, my buddy was bending down to pick up the ball that rolled towards him. And like every intramural sport, there's going to be that one try-hard who's trying way just doing too much.
You on your team?
No. At least the try-hard puts up points. I didn't do that.
Okay.
So my buddy went down to pick up the ball, and this try-hard decided he was going to dive for the loose ball. And they ended up clacking heads. Well, we didn't know at the time that they'd hit heads. If you've ever heard a nose break, you know the sound it made. It's that high crack sound. So his brother's on the bench at that point, and his brother's like one of my best friends, is one of my best friends. So I looked at him, was like, do you want me to deal with this or do you want to deal with this? And he's like, you deal with it. I don't want to talk to him. It's like, okay, typical brother answer. So I walk over there. Everyone's kind of huddled up around him. And I was like, well, what's going on? Are you bleeding? Like, what's happening? And so he gets up. He's like, oh, I'm fine. He toughs it out. And we get him home. Little beknownst to us, comes back, we find out way later, he'd been bleeding all night in his nose and he didn't tell anyone. So he'd been swallowing blood, puking up blood. So at the time we were in Utah, he was visiting his girlfriend at the time up in Idaho. So he flew back, and then he sends me a picture while he's on the plane, and he's got a very obvious dent in his forehead. And his exact words were, "Is this normal?" And my words were, "No, you should probably go to a doctor." So being the responsible college student he hung out the weekend, flew back down to Utah. So when we were there, ends up going to the doctor. Sure enough, he had a frontal skull fracture. So he ended up having a procedure done where they basically cut him from ear to ear and peeled his head over his face because it was just above his eyebrow, about, an inch above his left eyebrow. And I have the pictures of it, and sure enough, he's got a depressed frontal bone fracture. He was fortunate, though, that it was right over that frontal sinus. So none of the bone chips that were impeding or going inward were actually hitting the brain. They were caught where that sinus was. And he made a full recovery with no deficits or anything.
Lucky.
Very lucky. And especially, in our notes here, it even says parietal, frontal. Those are going to be your big two spots. No, like I said, he was fortunate it was his frontal bone, right? Because we had that big frontal sinus. But where he's really lucky, it wasn't a parietal fracture. Because those parietal fractures, think about the likelihood of a sinus underneath. And if you know anything about anatomy, we don't have a lot on the sides. So he could have ended up pushing those those skull chips right into his brain. And then who knows what kind of person he'd be if he would be alive at this point.
Yeah. And you think about why the frontal and parietal, you think of, car accidents and rollovers, that going back to kind of that mechanism of injury. You show up on that car accident where they've been ejected or that rollover type injury, you're going to have to think of these major head trauma as well as other multi-system trauma, but specifically with head trauma, thinking about those skull fractures and that kind of thing with that much energy that's occurring during an accident like that.
Yeah, it's definitely back of the mind stuff. It's the same as like with collars, right? If the mechanism's great enough, you're probably going to put a collar on.
Which I have something to say about collars, but we can talk about it later.
Sounds like that's a personal bias showing up.
Sounds kind of obvious.
Research.
Yeah. But those depressed skull fractures don't always present the same as like a concussion, right? You're not going to have the same questioning and repetitiveness and the amnesia and everything else that goes along with it. Like, your friend was totally fine all day, no repetitive questioning, no real hint that he was even concussed.
I didn't spend a lot of time around him during the days, I'm being transparent. But assuming so, yes.
He's not the sharpest tool in the shed, I'll give you that one.
Fair.
But I had a car accident that did the same thing. He hit his face on the A-post of his car, depressed skull fracture of the front, and he was ANO times 3. He knew all of my orientation questions except for kind of what had just happened, but no repetitive questioning. He was able to answer all my stuff appropriately, but he had a hole in the front of his face. And I was like, that's
not normal.
that shouldn't be there.
Yeah, I mean, it's knowing what's going to happen too, right?
Mm-hmm.
They may be presenting this way, but with something like that, high potential for deterioration. So we got to expect that moving forward as well.
And then you can't rule out a concussion necessarily, right? Force was there great enough to break skull. There's force great enough to bounce brain.
We can have all these injuries at the same time that we're going to talk about. It doesn't mean just because you have a depressed skull fracture that you can't have a concussion. We can have all of these injuries, and we've all had those patients. So it's
and like we kind of talked about earlier, we're line of sight medicine.
Yeah.
So we're just not going to know. We just got to treat them appropriately, get them to the right facility. Surgical, like trauma is a surgical disease. Nothing we can do to fix it.
Yeah. Yeah, I say it all the time for especially basic EMTs, right? Like we act like we have a lot of cool stuff we can do, but we don't, right? We're pretty limited in what we can do. And the number one thing we can do, especially basic EMT, is be really good at recognizing sick versus not sick and being really good about extrication and transport quickly to get them to the people that can, because we don't fix people, right?
No, we're Band-Aids.
Yeah. But we can be really good at recognizing that something is majorly wrong and getting them to where they can be fixed.
Yeah.
Right. To me, that's really probably the number one thing a good EMT is good at.
Yeah. And I talk about this a lot too, is like, I'm a medic, but I can't be a medic if I don't have medic stuff. But you can be a BLS EMT with just anything you can MacGyver, and that goes a long way. BLS saves ALS to some extent.
Oh, yeah.
And we need to work within our scope of practice, but as EMTs, we need to have a scope of knowledge above our scope of practice. I always talk about that. Like, just because you're an EMT basic doesn't mean you shouldn't learn above what you're able to practice. Always practice within your scope, but you should strive to kind of learn above your scope.
I mean, I'm sure I'm speaking for all of us too. Like, we all have that EMT where, we're grateful they're listening to the questions we ask. And like, I'm asking the right questions. I turn to say, hey, let's get a 12 lead. And they already got the stickers going and they're paying attention. They're thinking past me. And that is a skill and a value all on its own.
Yeah. I tell a story all the time of having a good EMT partner. I had a medic intern. I was his preceptor, and we went on a guy. We're not sure if it was so he was super drunk downtown at one of the bars and pushed a bouncer, and you might know the story already. Yeah. He pushed a bouncer, and we're not sure if it was when the bouncer punched him or when his head hit the ground after he fell over getting punched that knocked him out. But for whatever reason, dispatch had just dispatched me and my partner initially, and so get on scene. And he's laying there. He's GCS like 4 or 5 on the ground. And so we, thankfully, were you on the second ambulance?
I was at the hospital.
You were at the hospital. Okay. Yeah. Thankfully, another crew had heard that call go out and saw we were alone. And so they were clearing and just came to meet us. So we had extra hands. But so we start to like get this guy ready to go. Like we're gonna backboard him to the gurney, right? And we roll him, and he just starts like projectile vomiting all over the place, which head injuries is something that we see, right? And so we get him onto the gurney. We're managing the airway the best we can with this trauma patient who's vomiting. We get him in the back, and it's like we got to RSI this guy, right? Like we got to, for those of you maybe that are watching that don't know, RSI, rapid sequence induction, not intubation, rapid sequence induction, but we all call it rapid sequence intubation. That's where we sedate, paralyze, and intubate somebody, right? And this guy, he was vomiting, so we need to protect his airway. He's not able to protect his own airway, so we have to take his airway. And so we have everything set up. Everything's going really smoothly. It's me and my trainee, and then another crew that has a medic, right? And so I'm talking to the medic. We're getting everything good, and we're both very methodical paramedics generally. And so, we have all our ducks in a row, and like, okay, we get to start this procedure. Everyone's like, cool, let's go for it. So we push the ketamine on this guy, and we're backing him after pre-ketamine, we're backing him. He's at like 99% SpO2, everything's great. Push the ketamine, he loses all his muscle tone, and like the compliance in the bag just went away 100%. Like we can't bag this guy. We're trying two-handed. People are changing different seals. We're trying to do airway maneuvers. Everything we can do is just not working right. And it's like his SpO2 is dropping really quickly. We're talking about like crash airway intubation, all this. And my medic trainee turns to me with an OPA in his hand, and he says, would you like to try one of these? And we put an OPA in that we had forgotten to do as all this was happening because we're medic brain up here, right? He hands me an OPA. We drop that OPA. It opens his airway, pulls the tongue off, and we start ventilating him perfectly. After that, his SpO2 rises right back up. His skin color returns, slow things down. First pass intubation, everything was good. He ended up having a brain bleed. But yeah, that was one of those things where, I mean, good BLS is we failed to do it. I failed to do it, and thankfully we had a good EMT who came around to be like, hey, stupid, like this is the first thing you should have done, that you're 25 steps beyond. You want to try this, and it did its job perfectly.
Basics are, I mean, we talk about treatments here down on the outline later, but the basics are really what save us on these patients every single time.
We had a good one.
Which one?
So Mike was in his paramedic FTO and I was in my advanced FTO. We go on a call. This dude or gal needs to be CPAP'd, right? So he's got it plugged into the wall. Everything's going great. We had to switch out the bottle. Mike, being paramedic brain up here, forgot to turn the bottle on.
Ali saved me.
So I just went, we should probably.
I owe my paramedic career to Ali after that day. Yep, I forgot about that.
I was like, you're welcome.
Not an accident that you forgot that.
So it's important. We need to not overlook those things. And
definitely.
you know, I think that there can, and one of the reasons we're here, right? Like we represent. I had a little pop in my.
Yeah, I had that too, but that's good.
You know, we represent the BLS a little bit. We understand how important that is, and I think that sometimes, I know I felt sometimes as an EMT, like secondary on scenes, and that is so not how it should be. And so I think it's important for us to recognize, and for anybody maybe that's watching this that is not a medic or whatever, to recognize that, like, you know, BLS is where it's at, and we need to have respect for those BLS providers that really save us, because I have been saved multiple times by good EMTs that come through and, you know, show those little things like turn the bottle on for us or hand us an OPA when we're not there. So
Absolutely.
Yeah, if you're a basic provider, don't let people talk down to you, right? Like you are the cornerstone of everything that we do, and that should be our first things is thinking about that before we think about the ALS stuff.
And then being a basic provider, just generally know and own your scope. The better you know your scope, the better you're gonna be able to help. You know, and that's where thinking past us shows up.
Yeah, we have different roles sometimes, and you know, if you're really good at that, we can really support each other there. Back on track a little bit, back to head injuries.
Digressing.
So the next one would be open skull fractures, which I feel like my experience has mostly been like GSWs to the head. I'd imagine
GSWs.
That's what I was thinking about.
Yeah, probably anybody that's worked 911, GSWs, or maybe like rollovers or something, that you have like an open skull fracture.
GSW
generally, they're maybe still alive, but I mean, for the most part, when they have that open skull fracture with the GSW, they may be alive then, but I mean, the mortality rate on them is extremely high. So
that's when you got to think quality of life after. Just because we get them back, does that mean they're going to survive?
Right.
Yeah. Well, I mean,
we're still going to do our due diligence.
It's not wrong,
but the office with the quality of life here.
Maybe not.
Probably not great. We're just going to let you go.
We're still going to do what we do.
Call it. We don't have that option.
But that is you know, something. It could be a down the line thing.
Yeah, I don't have a lot of experience with just GSWs, but like I've heard some horror stories with some open skull fractures, and I think one thing I want to get across with that is when we have brain matter on the ground, you know, what is an injury incompatible with life versus what is one that we got a chance at actually, you know, even if they're not the same person, getting them back to life in general. You know, but excessive amounts of brain matter on the ground, brains on the ground, can't use it in the head. At certain points, got to make choices, and they're hard choices, but you got to make them.
I mean,
if they're still breathing, they still have a pulse. Like I've had that call where they, you know, GSW to the head, there's brain matter, and they're still breathing. And
got to run it.
Had even written the do not resuscitate on their arm, but that's not something that we can go off of. So we still, at some point, have to do what we have to do, even though the whole time you're like, this essentially, you know, futile.
It's not going to be a good outcome.
No, it's not.
Yeah. But
brainstem was still intact back to the A&P, right?
There you go. There you go. So traumatic brain injuries, you kind of brushed on it earlier, Wade, but when we're talking about traumatic brain injuries, there's going to be the primary injuries, right? And so that's important for us to remember. So that's going to be that direct impact. That's going to be your primary injury. But then there's also secondary injuries we need to think about. So some of that is stuff that we can help to manage, like hypoxia is going to be a secondary injury, hypotension. That cerebral edema is something we can recognize. We're not going to evacuate the cranium in the field. Nothing we can do. I mean, maybe Flight Medic Mike can do something cool there, but nothing we can do.
Show us something crazy.
So this is where I think, as EMTs especially, I mean, this is where we make our money with our brain injury patients, right? So when we're talking about TBIs and that secondary injury, especially, this really goes with any head injury. We're avoiding what we call the H-bombs. We're avoiding hypoxia, we're avoiding hypotension, and we're avoiding hypo or hypercapnia, which is essentially a fancy way of saying keep their respiratory rate within like a normal range. And so as an EMT, you can recognize all of those things. Is their airway open and patent? Do we need to open that airway and suction? Do we need to start ventilating that patient? And then we're ventilating within that normal rate. And then as far as avoiding hypotension, treat them for shock and transport to the hospital. And then if they have hypertension on the other end of things, we can sit them up a little bit, sit that head of the bed up 30 degrees. And that's essentially, even in like flight paramedic protocols, like that's all of our basics that we do first before we move on to anything else is, respiratory rate within normal rhythm or within normal rate, good rhythm. And, we're essentially assessing those ABCs first and foremost, avoiding those H-bombs. So
with those H-bombs, like specifically hypercapnia, because at the BLS level they don't have capnography, but they have capnometry, right? So running those numbers. So I think it'd be good to maybe talk about adjusting rates.
Yeah. So you'll hear a lot of different things. A lot of the newest research out there is that if and only if they're showing signs of herniation of that brainstem, so like that posturing, the Cushing's reflex, which we'll talk about here in a minute. So that hypertension, low heart rate, irregular respiratory pattern. If they're showing signs of that, then we're going to hyperventilate them to a range of 30 to 35 millimeters of mercury.
While they're hypercapnic?
While they're...
hypocap. No,
we want to hyperventilate, so make them a little bit hypocapnic in that instance. Otherwise, we're shooting for normal ranges. 35 to 45 is our normal range on our end tidal. And so we're going to shoot for that every time unless they are herniating, and then we'll shoot for that 30 to 35. So even as an EMT basic, if you're working with a paramedic, it's really important that you kind of understand where the end tidal CO2 is, how to hook it up to a BVM. Put it, even if you have a BLS airway, put that between your BVM and that mask and utilize your end tidal CO2, because that's one thing we can really, it's kind of like that last ditch effort, right? At that point there, it's essentially what you're trying to do is cause vasoconstriction, create more room within that skull, that cavity, kind of going back to that Monroe-Kelly doctrine, creating that space for that brain matter to kind of stay up there and not herniate. So that's kind of our last ditch effort as far as ventilation.
Fun facts. I was Mr. Mike Zinn's first reserve trainee. And before I even went with him, the first thing he said to me was, "Hey, do you know where end tidal is? If you don't, you better figure it out, because I use it all the time." So that's very on par.
That was like 6 years ago.
I burned that one. I know where it is still, back of the bag. I still know.
And he also got called Nick on our first RSI together. So I still call him Nick to this day. I don't think anybody else understands that joke. But
best nickname of all time.
Now millions of people will get the joke, right? The world will get the joke. Yeah, it's really interesting. When I started, hyperventilation of head injury patients was just common. It's just what they did for everybody. And now we've moved away from it. I don't know that most ground transport protocols are probably even talking about hyperventilation anymore. I think I don't know about like your local your protocols now. I don't think it's really something we talk about. And I think maybe it's just one of those training level things that maybe, at the flight medicine level, you maybe have a little higher training to be able to. And
we have ventilators that really can dial in exactly what we want to do. So it's a lot easier at that level than to squeeze a little bit more to the bag as opposed to, So that's probably why.
Yeah. We've touched on it a time or two, but it's more that the Shane Stokes respirations that we're looking for, which is in that Cushing triad that we'll get to in a minute. But yeah, as far as just kind of, I'm not going to hyperventilate a brain injury unless I have a CO2 reading. Because if it is the opposite, if they're already hypo, then I don't want to blow the rest of that CO2 off.
Yeah, like one instance of hypoxia, hypotension, or deranged capnography is, I mean, I think it's like 80% morbidity, mortality, right? It's very significant. Don't quote me on the percentage, but it's very high. So we really want to especially do what we can to avoid all of that.
Yeah, so definitely, if you have the training, then maybe think about that. Otherwise, just treat like you would anybody else.
Yeah, oxygen, ventilate, get them going to the hospital. I mean, keep it as simple as that. That's really what it comes down to after all those fancy words.
I'm going to add something to that, treating for shock just generally, right?
Yeah.
Blankets, positioning, those are going to be huge.
Yeah, don't forget there are many other, other things going on. So
well, shock's hard to identify, so you're never wrong, over treating a patient, because it's not like shock treatment's that intrusive or that, it's not going to cause too many problems. Just oxygen, blanket, positioning, you're already halfway there anyway. Most of the time they're supine. Most of the time we got a blanket on them. Yeah. As well throw the oxygen on, cover your bases.
But especially understanding that neurogenic shock, right? Like it's kind of backwards from your typical shock presentation, right? They're flushed, hypertensive, they have all this stuff going on. If you can know Cushing's triad and then neurogenic shock on your traumatic brain injuries or brain injuries in general, you'll have a little bit better path to go on as far as treatment plans.
Agreed.
And then, back to TBIs a little bit. You might have said this earlier, but the contra coup injuries are something we need. I mean, it's not going to change anything, right? It's just kind of a mechanism thing for us to think about. And so, hard deceleration is something that we can see for a lot for brain injuries, and that the contra coup is going to be that hard deceleration. The brain goes forward into the front of the skull, and then just, Newton's laws of physics, right? Like it's going to hit against the front of the skull, and then it's going to slap back to the back of the skull. So contra coup is going to kind of ping pong around in the head a little bit. And so we might have multiple injuries in different places of the brain because of that contra coup. So
where the head goes, the brain follows. So if the head stops, the brain stops.
Yeah.
So we look at starring of the windshield.
Yeah. Bingo. That's going to be the big one.
Yeah. Windshield, steering wheel. Look for changes there.
Doesn't have to be MVC, but that's our most common example.
Yeah, and that's why I'm saying most just deceleration is what we're going to see that most likely. Where the brain keeps going and the skull stops.